Welcome to the Deep Dive, the place where we take the densest, most foundational knowledge and transform it into the most essential study session you'll ever need.
Today, we are taking a comprehensive shortcut through Chapter 55, Assessment of Integumentary Function, straight from the core text of medical surgical nursing.
Our mission today is laser-focused. We are not just summarizing, we are exploring the integumentary system, so that's the skin, hair, and nails, as a dynamic living system.
Exactly. We're going to dive deep into the structures, the functions, and, most importantly, how to recognize those deviations that can serve as really powerful clinical clues to systemic illness.
And if you are a nursing student or a practicing clinician, you know this knowledge is just immediately applicable because you are assessing skin on every patient, every single shift. And the statistics really confirm this. I mean, as many as 1 in 3 people in the United States at any given moment are dealing with some kind of skin disorder or disease. You just can't afford to overlook it.
You really can't. It truly functions as the mirror of our systemic health. We often find that dermatologic manifestations are the first visible signs of some serious underlying conditions.
Like what, for instance?
Well, we're talking about everything from hepatitis to certain malignancies, or even the early stages of an autoimmune disease. So a meticulous, knowledgeable assessment is really your frontline defense in catching those subtle clues before they progress.
Okay, so before we jump into the anatomy, let's establish some foundational clinical language. Let's just quickly build a picture of what gives skin its incredible protective power and what happens when that protection breaks down.
We have to start with the building blocks, and that means starting with keratin.
Okay.
This is an insoluble fibrous protein that provides the structure, and really the toughness, to the outer layers of the skin, hair, and nails. The cells that make this are called the keratinocytes.
So keratin is what makes it tough.
Exactly. It's what allows the skin to resist external trauma and pathogens.
And then when we look at skin color, that's largely driven by melanocytes, right?
Correct. These cells produce the pigment melanin, which, determines our skin color, but also serves a crucial function in protecting the underlying tissues from harmful ultraviolet radiation.
Got it. Now, when we see a patient, we are often looking for signs of injury or inflammation. A very common finding is redness, which we clinically call erythema.
Right. Erythema is that telltale redness that's caused by localized dilation of the superficial capillaries. It signals inflammation, heat, or fever. But it's important to know that redness isn't always inflammation. Sometimes it signals internal bleeding.
So that's where we get into the difference between the vessels just widening versus them actually leaking.
Exactly. When blood leaks out of the vessels and into the skin and the underlying tissue, we call that ecchymosis, what most people would just call a bruise.
Okay.
And you'll see it change color dramatically over time, starting purple or black and then fading to green, yellow, and brown as it heals.
And what if that bleeding is really small?
If that blood leakage is extremely tiny, appearing as these little pinpoint red spots, usually just 1 to 2 millimeters in size, we call those petechiae. Recognizing whether redness is blanching erythema or non-blanching petechiae is just a fundamental assessment skill.
Okay, with those terms in our toolkit, let's quickly outline the scope of this deep dive, mirroring the core learning objectives of the chapter. We are going to ensure you can confidently describe the complex structures and functions of the entire integumentary system.
We'll also enable you to distinguish clearly between normal and abnormal physical assessment findings and how to integrate the patient's history with the physical exam. This helps us recognize the major alterations.
And this is critical for charting. We will master the classification and documentation of skin findings. We'll compare and contrast the patterns, distributions, and the defining characteristics of primary versus secondary lesions.
And finally, we'll spend some serious time on the systemic connections. So, distinguishing the common dermatologic manifestations of diseases like HIV and diabetes, and identifying the modern diagnostic tests used in dermatologic evaluation, along with all the essential nursing implications for each. That roadmap ensures we cover the breadth and depth required for clinical competence.
Let's jump straight into the anatomy, starting with the skin's crucial role. It's not just a wrapper, it's the body's largest organ system, weighing in at nearly 15% of total adult body weight. Its functions are absolutely essential for survival.
It really is the ultimate multitasker, just maintaining homeostasis. It's our primary physical barrier against external threats like pathogens and chemicals. It regulates temperature, manages water and electrolyte loss, and gives us continuous sensory input about pressure, pain, and temperature from the environment.
So if you compromise this barrier.
Then the risk to life becomes immediate and immense.
Okay, let's break down the classic layered structure. The three main components we have to visualize, starting with the most superficial one, the epidermis.
The epidermis is the outer layer, and it's composed primarily of stratified epithelial cells, the keratinocytes. What's interesting is its thickness is incredibly variable, which is a detail we often gloss over.
How so?
Well, it's a delicate 0.05 millimeters over the eyelids, for example, but it's incredibly thick and resilient at 1.5 millimeters on the palms and soles of the feet, which just reflects the mechanical stress those areas have to endure.
And it's a dynamic structure, right? It's constantly renewing itself. How do those four distinct layers work?
So cells are born, and they continuously divide in the innermost layer, the stratum germinativum, sometimes called the basal layer. As they mature, they differentiate and flatten, moving upward through the stratum granulosum and stratum lucidum. That's a layer that's only really visible in thick skin, like the soles.
So this differentiation process, they're basically becoming tougher and drier as they move up.
Essentially, yes. They're dying as they move up. And they eventually reach the external protective cap, the stratum corneum.
Which is functionally the most important part of the barrier.
Oh, yes. It's metabolically inactive. It's essentially a stack of dead, flattened, keratin-packed cells, which is exactly why it's so tough. This outer layer is almost completely replaced every 3 to 4 weeks, ensuring continuous barrier integrity.
And that keratin is the key.
It's critical not just for repelling pathogens, but maybe even more importantly, for preventing excessive fluid loss. Its effectiveness really relies heavily on its specific lipid mixture, which we'll talk more about in part 2.
Beyond the keratinocytes, you mentioned specialized cells. Let's delve a little deeper into their unique roles in the epidermis.
Certainly. We already highlighted melanocytes, which produce melanin. And a key point here, one that's often misunderstood, is that differences in skin tone are not due to the number of melanocytes, which is generally similar in all races, but the activity and the amount of melanin produced and distributed.
That's a great clarification.
Then you have sensory input. So Merkel cells are found near the dermal junction, and they're thought to transmit light-touch sensory messages to the adjacent nerve fibers.
And the Langerhans cells, these are fascinating because they give the skin a direct active link to the adaptive immune system.
That's a crucial insight for nurses. Langerhans cells are dendritic, clear cells that are, key participants in the immune system. They basically patrol the epidermis.
Like security guards.
Exactly. When they encounter an invading antigen, say a virus or a chemical allergen, they process it, acting as an antigen-presenting cell, and then they physically transport it to the nearest lymph node to activate T lymphocytes. Clinically, they initiate and mediate delayed hypersensitivity reactions, like allergic contact dermatitis. They are the skin's immune surveillance system.
Now let's talk about the junction itself. The connection between the epidermis and the dermis isn't just a straight line, it's interlocked.
Right, and that interlocking structure is vital for resilience and function. The epidermis creates these downward extensions called Reed bridges, which fit into upward projections from the dermis called dermal papillae.
So they fit together like puzzle pieces.
Perfectly. This strong anchoring system ensures the two layers don't separate easily, unless, shearing forces are applied, especially in aged skin, and it increases the surface area for essential nutrient exchange, since the epidermis is avascular. This topography also determines the surface ripples that form our fingerprints.
And below that junction lies the dermis, the structural heart of the skin.
It is the largest portion, and it provides the bulk, strength, and elasticity. It's primarily connective tissue, dominated by strong collagen and resilient elastic fibers. It's subdivided into the papillary layer above and the denser reticular layer below. And this layer is highly vascularized. It contains the extensive network of blood and lymph vessels, nerve endings, hair roots, and various glands we'll get to in a moment.
And finally, that foundational layer, the subcutaneous tissue or the hypodermis.
This innermost layer is fundamentally composed of adipose tissue and loose connective tissue. Its function is pure support and cushioning. It attaches the skin to the underlying muscles and bones, it protects nerve and vascular structures, and most significantly, it acts as the primary thermal insulator.
And that's what gives us our body shape.
Right, the distribution of this adipose tissue is what molds our body contours and allows for that essential skin mobility.
Let's transition to the appendages, starting with hair. It follows an incredibly precise, continuous cycle.
It's a marvel of regeneration. So hair is formed in the hair follicle, which is a cylindrical invagination of the epidermis that extends deep into the dermis, or even the hypodermis. The cycle is continuous, but it's asynchronous across the scalp. which is a good thing. Otherwise, we'd shed all our hair at once.
That would be alarming. So what are the phases?
There are three. Anagen is the active growth phase, and that lasts 2 to 6 years for scalp hair. Then catagen, which is a brief 2 to 3 month involution or regression phase. And finally, telogen, the 2 to 3 month resting phase, which culminates in shedding.
So when a patient complains of hair loss, knowing that typical shedding rate, about 100 hairs per day, gives us a baseline for determining if the loss is truly excessive.
Exactly. And clinically, understanding where regrowth capacity resides is vital, particularly when you're dealing with scarring. The hair follicle bulge, a small projection on the side of the follicle, is where the stem cells necessary for regeneration live.
So if that's damaged, the hair's not coming back.
Correct. If physical trauma, inflammation, or disease destroys this bulge, the hair loss is permanent. This is different from, say, chemotherapy-induced alopecia, which typically only damages the actively dividing root cells and is often reversible.
Hair growth is also a sensitive marker for hormonal health.
It is, particularly because of androgen influence. Androgens control growth in areas like the beard, chest, and axillae. So in women, if you see the appearance of hirsutism, that's excessive, coarse hair growth in these male pattern areas, especially when it's coupled with other symptoms like irregular menses or sudden weight gain, it signals the need for a comprehensive hormonal workup to rule out conditions like polycystic ovary syndrome.
And the functions, though often overlooked now, were historically crucial, filtering and insulation.
Yes. The fine hairs in the nose, ears, and lashes act as physical filters. And while we don't rely on it much anymore, the ability to make hair stand on end piloerection via the tiny erector pili muscles is a vestigial mechanism designed to trap a layer of warm air near the skin for insulation.
Next up, nails. They may seem simple, but they can offer deep insight into chronic systemic health.
Nails are hard, transparent plates of keratin. They serve protective and functional roles, but their appearance is often tied to psychosocial well-being. Good grooming matters to people. They grow continuously, averaging about 0.1 millimeters daily.
And the renewal rate is quite different for fingers and toes.
Strikingly different. Fingernails take about 6 months to regenerate fully, while toenails require roughly 18 months, which has huge implications for treatment adherence for conditions like fungal infections.
Yeah.
It takes a long time.
Finally, let's detail the two major categories of glands of the skin.
First, we have the sebaceous glands. These are typically attached to hair follicles, and they produce sebum, which is a fatty, lubricating secretion. Sebum's job is crucial. It conditions the skin and hair, keeping them soft and pliable, and its mild acidity helps maintain the skin's protective pH barrier against microbes.
And the sweat glands are split into two distinctly functioning groups.
Right. The eccrine glands are the most numerous and are found almost everywhere. They open directly onto the skin surface and produce a thin, watery sweat that's used exclusively for thermal regulation. This is a sympathetic nervous system function, the primary way we cool ourselves down.
And they can also activate for other reasons.
Oh, yes. They can also activate in response to pain or emotional stress, which is what gives you that cold sweat.
And the other group, the apocrine glands, are responsible for a different and sometimes socially sensitive function.
The apocrine glands are larger and limited to specific regions, the axillae, nipples, anogenital area, and periumbilical region. They become fully functional only after puberty. They secrete an oily sweat, which is actually odorless when it's secreted.
But it doesn't stay that way.
No. The resident bacteria on our skin, particularly Corneobacterium species, break down these organic molecules, producing volatile fatty acids, which creates the characteristic body odor.
And we mustn't forget the specialized apocrine variations.
Right. The ceruminous glands in the external ear are a modification of the apocrine gland structure, and they're responsible for producing that protective, sticky earwax or cerumen.
Now that we have the structures mapped, let's connect those structures to the skin's 6 core functions.
Yes. Understanding these functions is essential because it immediately tells you what risks the patient faces when their skin integrity is breached.
Let's start with the obvious one, but expand on the mechanism. Protection. How exactly does a layer barely a millimeter thick protect us so effectively?
Well, the primary barrier is the stratum corneum, and its strength is due to the chemical composition of the matrix between the dead cells. It synthesizes these long-chain water-resistant lipids, specifically ceramides, cholesterol, and free fatty acids, that are arranged in a very specific crystalline structure.
And that's what keeps water in and everything else out.
Pretty much. This lipid barrier makes the skin relatively impermeable to water-soluble compounds, UV radiation, and most microbes, while also preventing internal water loss. The intact skin itself also generates innate immunity and resists colonization by all but our normal resident flora.
Function number 2, sensation. It's the constant communication system between our body and the environment.
It is, thanks to the vast network of nerve receptor endings that monitor the environment in real time. These sense temperature, pain or nociception, pressure, and light touch. And while these are everywhere, the concentration is highest in the face, head, and distal extremities, which is why those areas are so sensitive.
Function number 3, fluid balance, is a delicate equilibrium.
It absolutely is. The intact stratum corneum absorbs some water but primarily prevents excessive water and electrolyte loss. We are constantly losing water through evaporation, which we refer to as insensible perspiration.
How much are we talking about?
In the average adult, this amounts to about 500 milliliters daily. However, and this is a critical clinical rule of thumb for nurses, for every 1 degree Celsius increase in body temperature, this insensible loss increases by about 12%. This factor alone makes fluid replacement critical in febrile patients.
And when that barrier is lost, as in severe burns, the losses become catastrophic.
Catastrophic is the right word. A major burn injury immediately removes the impermeable barrier, leading to massive rapid fluid and electrolyte loss that can precipitate hypovolemic shock if not aggressively managed in the critical care setting.
Function number 4, temperature regulation. This is how we dissipate the tremendous metabolic heat we produce.
The body has to shed heat through 3 primary physical methods. Radiation is the transfer of heat to a cooler nearby object without contact. Conduction is direct heat transfer to an object in contact, like the air or a cool surface you sit on. And convection involves the movement of warm air or fluid molecules away from the body surface.
And of course, sweating.
Right, the evaporation of sweat is a key driver of cooling, particularly in high-temperature environments.
And how is this process controlled internally?
It's driven by the sympathetic nervous system, specifically by controlling blood flow through the dermis. Normal skin blood flow is about 450 milliliters per minute. To dissipate heat, the sympathetic system vasodilates, increasing flow and transferring more heat to the skin surface. To conserve heat, it vasoconstricts, decreasing flow.
So sweating isn't always on.
No, clinically, you should remember that sweating for temperature regulation does not actually begin until the core body temperature exceeds the normal set point of 37 degrees Celsius.
Function 5, vitamin production. Specifically, vitamin D synthesis, the skin acting as a factory.
Yes, when the skin is exposed to UV light, it synthesizes vitamin D, or cholecalciferol. And this is essential for calcium absorption and preventing debilitating conditions like osteoporosis and rickets.
But we don't really recommend sun exposure for that anymore, do we?
We don't. While research suggests relatively short periods of sun exposure, say 5 to 30 minutes twice a week, may be sufficient, the current clinical consensus strongly favors obtaining vitamin D through diet and supplementation. We actively counsel patients against intentional sun exposure because the increased risk of skin cancer far outweighs the benefit of synthesizing D this way.
And finally, the skin's crucial role in the immune response function.
We covered the specifics of the innate barrier, the stratum corneum, and the adaptive system, the Langerhans cells. It's important to see the skin as a primary immune organ. It doesn't just passively block, it actively surveils, it initiates nonspecific inflammation when it's injured, and it processes and presents foreign antigens to activate the body's entire defense system.
Now, let's address a reality every nurse faces: the aged integument. What physiological changes make geriatric skin so incredibly vulnerable?
The changes are profound and complex. They're driven by intrinsic factors, but they are severely accelerated by extrinsic factors like sun damage. We see decreased dermal thickness, degeneration of collagen and elastic fibers, increased vascular fragility, and significantly reduced function of the sweat and sebaceous glands, often linked to declining androgen levels.
The result is visible, but the invisible changes are the most dangerous clinically.
Absolutely. The visible signs include dryness or xerosis, wrinkling, uneven pigmentation, and benign proliferative lesions. But the most serious clinical alteration occurs at the dermal-epidermal junction. Remember those Riecky ridges and dermal papillae we talked about?
Yes, the interlocking parts.
Well, they flatten significantly with age.
Which means the anchor holding the skin layers together weakens.
Precisely. This loss of anchoring sites means aged skin becomes highly vulnerable to shearing injury. Even minor friction, or drag like pulling a patient up in bed without using a proper lift sheet, can cause the epidermis to easily shear away from the dermis, predisposing them to skin tears and pressure injuries. Nurses must be hyper-vigilant about friction and shear reduction in all aspects of care for older adults.
We also see the impact of subcutaneous loss.
The hypodermis loses elastin, collagen, and fat, and this loss diminishes the protective cushioning. It reduces muscle tone appearance, and it severely impacts thermal insulation, making older adults much more sensitive to ambient temperature changes.
And the vascular changes directly impact recovery time, correct?
Yes. The number and size of blood vessels, especially capillaries, decrease. This reduced blood supply means slower nutrient and oxygen delivery to the site of an injury or inflammation, which is a primary reason why wound healing is consistently delayed in the older adult patient.
Let's touch on the common benign lesions listed in Chart 55-1 that nurses need to recognize as just normal signs of aging so they don't cause unnecessary concern.
This saves everyone a lot of anxiety. For example, cherry angiomas, those small, bright red papules, are extremely common with age and typically require no action. Solar lentigo, or liver spots, are those unevenly pigmented brown macules that result from sun exposure.
And what about seborrheic keratoses? They can look pretty concerning.
They can. They are perhaps the most common. Brown, crusty patches that often look like they are stuck on the skin. They can be rough, and they often cause confusion, but they are benign unless they get irritated or infected. Recognizing telangiectasias, tiny dilated blood vessels near the surface, is also important, as they are often just part of increased vascular fragility in aging skin.
The key differentiating factor in skin aging is the difference between normal wear and tear and accelerated damage due to photoaging.
Photoaging is chronic, cumulative, UV-induced damage, and it produces a vastly different clinical picture than normal aging. You see profound loss of elasticity or elastosis, deep, coarse wrinkling, mottled pigmentation, atrophy, and a far higher density of precancerous and cancerous lesions.
Which just reinforces the importance of sun protection.
It reinforces that preventative sun protection, started early in life, is one of the most effective long-term health interventions you can possibly do.
Transitioning to the clinical assessment, this is where we stop thinking about the textbook diagrams and start looking at the patient. And it begins, as always, with a detailed narrative.
We are building the story of the patient's skin problem, and we're following the framework in Chart 55-2. We need to go beyond simply noting rash or itch. We need meticulous detail on the onset, location, duration, character, and severity of the chief complaint.
Specific questions are what differentiate a good history from a great one. We need to investigate the triggers.
Yes. Has this occurred before? If so, what was the first site affected? And how quickly did it spread? Is there tingling, numbness, or loss of sensation associated with it? And we must ask about the patient's current regimen. What specific soaps, detergents, cosmetics, non-prescription, or herbal preparations are they applying to their skin? Are they exposed to specific plants, chemicals, or allergens in their home or work environment?
And crucially, we must assess the personal and psychosocial impact.
Skin conditions can be highly visible and often stigmatizing. So we need to ask, how has this affected your sleep, your job, your relationships, or your ability to perform daily activities? This opens the door to evaluating the psychological distress, which can be just as debilitating as the physical symptoms, and it requires tailored nursing support.
We also can't ignore the genetic influences. Chart 55-3 provides examples that remind us that some integumentary conditions run deep in the family tree.
Absolutely. The list includes things like neurofibromatosis type 1, which presents with characteristic café au lait spots, to common predispositions like psoriasis. So the nursing assessment has to specifically look for family history across 3 generations, noting age at onset and lesion type.
And for the patient themselves.
For the patient, we assess for related abnormalities often seen in connective tissue disorders like unusual hair or teeth, vision changes, sun sensitivity, and delayed wound healing time. We specifically look for the number, location, and size of café au lait spots because having 6 or more that are larger than 1.5 centimeters is actually diagnostic for neurofibromatosis.
Okay, moving to the physical exam. Inspection and palpation are the main techniques, but preparation is vital to prevent missing subtle findings.
Proper preparation is non-negotiable. The room must be exceptionally well lighted. Natural or full spectrum light is ideal, and comfortably warm. The patient needs to be completely disrobed for a head-to-toe assessment, including the scalp, mucous membranes, hair, and nails, ensuring adequate draping for privacy. And for infection control, standard procedure is always to wear gloves.
What exactly are we observing and palpating across the general assessment?
We begin with observation. Overall color, temperature, moisture. Is it oily, dry, damp? Texture. Is it rough, smooth, firm? The presence of any lesions, and vascularity. We assess skin mobility, how easily it moves over the subcutaneous tissue, which is reduced in conditions like scleroderma. Then we palpate specifically to assess turgor for hydration status and check for edema or underlying hardening of tissues.
Accurate assessment requires acknowledging the variations introduced by different levels of melanin. How does a nurse accurately assess color changes in patients with dark skin? This section needs significant depth.
This requires specific knowledge and focused inspection. Healthy dark skin typically has a reddish base or undertone. The key is to look at areas where pigmentation is naturally least dense. The buccal mucosa, the hard and soft palate, the conjunctivae, the lips, and the nail beds. These should normally be pink.
And there's another key consideration.
Yes, we must be aware that, in darker skin, any inflammation or injury often results in hyperpigmentation that can persist for months after the primary issue resolves, which can be a source of significant psychological distress for the patient.
Let's walk through the critical color changes detailed in Table 55.1 and discuss the focused assessment required for dark skin tones. Let's start with pallor.
If we suspect pallor, an indication of anemia or shock in a light-skinned patient, it's generalized paleness. In dark skin, generalized pallor appears as a subtle yellow-brown or dull gray cast. We confirm this by checking the color of the mucous membranes and conjunctivae. They will look ashen or gray.
Next, cyanosis, which signals unoxygenated hemoglobin. This can be masked entirely by high melanin levels.
It absolutely can be. In light skin, we see the bluish hue immediately in the nail beds and lips. In dark skin, the overall complexion takes on a generalized grayish cast. The most reliable areas to observe are the circumoral region, the skin around the mouth, and the conjunctivae, or beneath the tongue. If you suspect poor circulation, you have to assess the capillary refill time carefully and look for signs of chronic hypoxia, like clubbing.
How about erythema, or redness? This seems like the toughest one to confirm in dark skin through inspection alone.
It is often completely invisible as bright red or pink. Instead, inflammation often manifests as a subtle, purplish-gray tinge or perhaps a slightly darker brown than the surrounding skin. Inspection is insufficient here. The crucial clinical skill is palpation. You must palpate the area for secondary signs of inflammation, increased warmth compared to adjacent skin, tautness, or actual hardening of the deep tissues.
And finally, jaundice, the yellowing caused by increased bilirubin levels. Where do we look for the earliest signs?
Jaundice is best observed in the sclerae and mucous membranes. In light skin, it's usually obvious. In dark skin, you need to check the sclerae near the limbus. That's the border between the iris and the sclera. Or, for confirmation, inspect the junction of the hard and soft palate in the mouth, which tends to accumulate the yellow pigment earliest.
And the final finding, ecchymosis, bruising.
Bruising results from blood leaking out, presenting initially purple-black. While the fading colors like green and yellow are harder to track in dark skin, we note that ecchymosis is a frequent finding, especially in older adults, because of that age-related increase in vascular fragility.
When a patient presents with a rash or intense itching, pruritus, the assessment must classify the findings immediately.
First, we localize the pruritus and identify any excoriation, scratch marks that might complicate the picture. A great trick for visualizing subtle redness, especially in pigmented skin, is to gently stretch the skin. This decreases the reddish tone, making the elevations and borders of the rash more defined.
And a pen light can help too.
Yes, using a pen light held laterally can really highlight elevations. We must systematically check all areas, the borders, the mouth, the ears, and palpate the regional lymph nodes for enlargement.
The absolute most critical documentation skill here is distinguishing between primary and secondary lesions. A primary lesion is the initial manifestation of the disease. A secondary lesion results from external factors like trauma or scratching or just the healing process itself. Let's walk through the major types from Table 55.2, focusing on defining characteristics.
Starting with flat, non-palpable lesions, which are merely changes in color. A macula is small, less than 1 centimeter. Think a freckle, a petechia, or a flat mole. A patch is simply the larger version, greater than 1 centimeter, like you see in vitiligo, or a large ecchymosis.
Next, the elevated palpable solid lesions.
A papule is small and elevated, less than 0.5 centimeters, like a wart or an elevated mole. When papules merge, or if the initial lesion is larger than 0.5 centimeters and flat-topped, it becomes a plaque. Classic examples would be psoriasis.
And if it's deeper?
If the lesion is deeper, extending into the dermis, it's a nodule, 0.5 to 2 centimeters like a lipoma, or the larger form, a tumor, over 1 to 2 centimeters, often indicative of malignancy like a carcinoma.
And the fluid-filled primary lesions.
A vesicle is small, under 0.5 centimeters, and it contains serous fluid waif. Classic examples are the blisters of herpes simplex or poison ivy. A bulla is just a large vesicle over 0.5 centimeters, such as a large burn blister. A pustule is defined by its contents. It's pus-filled, which you'd see in acne or impetigo. A cyst is an encapsulated mass, either fluid or semi-solid deep in the dermis or subcutaneous tissue. And finally, the quick change artist, the wheal or hive, a transient, elevated, localized area of edema caused by fluid movement into the dermis.
Now on to the secondary lesions, the consequences of time or trauma. We must be able to recognize these results.
If the skin has lost its superficial epidermis, that is an erosion. It doesn't extend into the dermis and usually heals without scarring. An ulcer is the full-thickness loss extending past the epidermis, which often bleeds and results in scarring, like a pressure injury. A fissure is a linear crack extending into the dermis, common with severe dryness or chapped hands. And scales are flakes of dead epithelium, often dry and flaky, which you'd see in psoriasis or severe dandruff.
And what about the final stages of healing and chronic trauma?
A crust is simply dried residue of serum, blood, or pus, basically a scab. A scar is the replacement tissue after healing. A keloid is a significantly hypertrophied scar that results from excessive collagen formation. It often extends beyond the original wound margins and is notably more common in individuals of African descent.
And lichenification.
Lichenification is the thickening and roughening of skin, so it often looks leathery. It's caused by chronic, persistent rubbing or scratching, common in long-term eczema or contact dermatitis.
Once we identify the type of lesion, documentation requires precision about location, size, and pattern.
Yes, we have to use exact terminology.
Yeah.
Color, size, always using a metric ruler, precise location, and the pattern of eruption. For pattern, is it discrete, separate, confluent, merged, linear, annular, ring-shaped, or critically zostriform, following the distribution of a nerve root, which is a classic diagnostic pattern for herpes zoster or shingles.
So the location itself is a clue.
A huge clue. Knowing that psoriasis favors elbows and knees, while seborrheic dermatitis favors the face and scalp, helps narrow the diagnostic field immediately.
And if we are assessing an acute open wound, the assessment checklist expands.
It does. We have to inspect the wound bed itself. Is there necrotic tissue, or is there healthy, beefy red granulation tissue? We assess the exudate for color, amount, odor. We measure the depth and diameter precisely, and we always check for undermining. That's an extension of the wound under the surface skin, which suggests deeper tissue damage and requires aggressive management.
We must move beyond texture and lesions to assess vascularity, hydration, nails, and hair, starting with vascular lesions from Table 55.3.
We look for petechia, those 1 to 2 millimeter macules indicating bleeding tendencies or emboli. Angiomas, like cherry angiomas, are common age-related papules. However, the spider angioma, a central red body with radiating branches, is a significant finding often associated with elevated estrogen levels, such as in liver disease or pregnancy.
And telangiectasia.
Telangiectasia are small, dilated venous vessels, often spider-like or linear, that you'll see on the legs or chest. A key detail: they do not blanch with pressure, unlike blanching erythema.
Hydration status is a quick check using turgor and edema.
Turgor is assessed by pinching the skin, usually on the clavicle or forearm. Decreased turgor, when the skin remains tented, is a sign of dehydration or simply severe skin dryness. Edema is swelling, and it presents as tense, shiny skin. If you find pitting edema, you need to document the depth and duration of the pit, grading the severity from 1+ to 4+ diva.
Let's discuss nail assessment. The normal angle is our key reference point.
Yes, the normal angle between the nail plate and the proximal fold is 160 degrees. Any straightening to 180 degrees or greater, which is known as clubbing, where the nail base feels sponge-like, is a serious sign.
What does it signal?
While it could occasionally be idiopathic, clubbing is strongly linked to chronic hypoxia, commonly seen in chronic pulmonary disease, emphysema, or congenital heart defects.
Other nail abnormalities are great windows into a patient's systemic history.
Oh, absolutely. Bowlines are transverse depressions that result from a temporary growth arrest due to severe illness, high fever, or trauma. They allow you to actually date the illness based on nail growth speed. Paronychia is inflammation and tenderness of the tissue around the nail, usually infectious. Pitted surfaces often correlate with psoriasis, and spoon-shaped nails, or koilonychia, are a classic indicator of severe iron deficiency anemia.
Finally, the hair assessment: texture, color, and distribution.
We inspect the scalp for lesions and texture. Dry, brittle hair might signal overuse of dyes, but it must prompt an investigation for underlying conditions like thyroid dysfunction. Distribution is also critical. An adult pubic hair pattern that's characteristic of the opposite gender can indicate a significant endocrine disorder.
And when assessing alopecia, hair loss, differentiating the cause is paramount.
It is. If the loss is patchy, we look for physical causes like traction from hairstyles or an infection. Alopecia areata presents as well-defined, often circular patches, and usually has spontaneous, unpredictable regrowth potential. The most common form is androgenic alopecia, or pattern baldness, which is driven by heredity and androgens.
And that presents differently in men and women.
Yes. In men, it presents as a receding hairline and crown thinning. In women, it rarely leads to complete baldness, typically manifesting as thinning at the vertex of the scalp while sparing the frontal hairline.
This section is critical. We must integrate our skin assessment findings directly into the management of patients with chronic systemic disease. Let's start with the severe consequences of diabetes.
Diabetes severely compromises skin health because of two primary mechanisms: microvascular damage and neuropathy. Poor circulation starves the skin of oxygen and nutrients, which leads to slow healing, and high glucose levels create an ideal environment for microbial proliferation.
What are the specific dermatological findings linked to this pathology?
One of the most common is diabetic dermopathy, or shin spots. These are small, brownish, atrophic patches, usually appearing on the lower anterior legs, and they're directly linked to small vessel damage and minor trauma. We also commonly see stasis dermatitis, an eczematous eruption on the lower legs resulting from chronic venous insufficiency, which is compounded by diabetes.
And that leads to fragile skin.
Extremely fragile. The skin becomes thin, dry, and fragile, leading to poor barrier function and eventual permanent hyperpigmentation and texture changes.
And the infectious complications are massive.
They are. Patients are highly susceptible to both bacterial infections, like folliculitis, furuncles, and carbuncles, and fungal infections. Fungal infections, particularly candida, which appears beefy red and moist with satellite pustules and folds, and dermatophyte, which is dry, scaly, and often on feet and nails, are persistent. And if blood glucose is poorly controlled, any infection heals just agonizingly slowly.
Which brings us to the worst-case scenario, foot ulcers leading to amputation.
This is often triggered by peripheral neuropathy. The patient loses protective sensation and may sustain minor trauma stepping on a tack, a poorly fitting shoe, without ever realizing it. These injuries can rapidly progress to deep, large ulcerations that are notoriously difficult to treat because of severe, concomitant peripheral artery disease and poor blood flow. They represent a leading cause of non-traumatic amputation worldwide.
Let's turn to Human Immune Deficiency Virus, HIV. Skin signs are often the sentinel warnings of immune decline.
They are present in over 90% of HIV-infected patients, and they correlate strongly with the severity of immune compromise, specifically the CD4 plus T lymphocyte count. As that count drops, the clinical manifestation severity increases.
Which dermatologic findings are the most urgent red flags for nurses, indicating the patient has crossed that critical threshold into severe immune decline?
Certain conditions are highly suggestive that the CD4 plus count is critically low, so below 200-300 cells per microliter. These include Kaposi sarcoma. Those are vascular lesions that can range from pink to dark purple plaques or nodules persistent, severe oral candidiasis or thrush, oral hairy leukoplakia, and extensive facial molluscum contagiosum.
And other common infections present differently too.
Yes, otherwise common bacterial or viral infections tend to present in an unusually severe, widespread, or persistent manner in HIV patients. Acute flares of chronic conditions like severe seborrhea or acne may also indicate a new underlying opportunistic infection is emerging.
When assessment suggests malignancy, a rare condition, or some systemic connection, definitive testing is required. What is the overarching nursing role during diagnostic evaluation?
Our role is comprehensive patient advocacy and procedure management. This involves detailed education about the test's purpose and expectations, ensuring informed consent is obtained for invasive procedures like biopsies or photography, meticulous specimen management, ensuring proper labeling and transport, and providing post-procedure care and timely follow-up of results.
Let's start with the most definitive method, the skin biopsy.
This procedure obtains tissue from microscopic examination. It's often necessary to definitively rule out malignancy or aid in the diagnosis of complex dermatosis. Biopsies can be taken in three ways: shave, which removes the superficial skin; excision, which removes the entire lesion and margins; or punch, which uses a small circular instrument to remove a deep core of tissue, including the dermis and sometimes subcu fat.
And that tissue can be tested further.
Right, the tissue can then be subjected to specialized staining, such as a Gram stain for bacteria or a PAS stain for fungal elements.
To identify external triggers, we rely on patch testing.
This is used to identify specific contact allergens, like chemicals, nickel, or fragrances. Small amounts of suspected allergens are applied under occlusive patches, usually on the back. The patches stay on for 48 hours, and the nurse then assesses the area 72 hours later.
And you're looking for a reaction.
Yes, and the reactions are graded clinically. A weak positive might be just erythema and fine elevation. Moderately positive could have papules and vesicles, or a strong positive can have ulceration and pain. The primary nursing implication here is patient education. Rigorous, often lifestyle-changing avoidance of the identified allergen is necessary.
Other common non-invasive tests include skin scrapings and the zinc smear.
For scrapings, we use a scalpel blade moistened with mineral oil to gently scrape the surface of scaling lesions or burrows in the case of scabies. The material is mounted and examined microscopically for fungal elements, spores, or high-figure mites. The zinc smear is a quick technique for blistering conditions like herpes zoster, varicella, herpes simplex. Secretions from an active vesicle base are smeared onto a slide and stained to look for giant multinucleated cells, which are characteristic of herpes viruses.
Finally, the easily performed yet informative wood light examination.
The wood light is a specific long-wave ultraviolet light that must be used in a pitch-dark room. It causes characteristic fluorescence in certain conditions. It is used to differentiate between dermal and epidermal lesions. Epidermal lesions will fluoresce, and to identify subtle hypo or hyperpigmented lesions.
What's an example of that?
For instance, some fungal infections, like tinea capitis, will fluoresce a brilliant blue-green. The nurse's role is to ensure the patient's eyes are protected and provide reassurance, as the UV light itself is harmless.
Before I wrap up, we must ensure we address the crucial, non-physical component of dermatological care. The emotional toll of a chronic or highly visible skin condition is immense.
It cannot be overstated. Because the skin is our interface with the world, visible conditions can lead to devastating psychological distress, leading to social isolation, poor self-esteem, clinical depression, anxiety, and even job loss. Furthermore, chronic symptoms like unrelenting itching or pruritus disrupt sleep, causing chronic fatigue and just reinforcing the cycle of distress.
What is the nurse's imperative in managing this emotional burden?
The nurse must approach the patient with genuine understanding, thorough education, and sustained support. Critically, the nurse has to ensure their own physical behavior, their posture, facial expressions, and touch shows absolutely no aversion or hesitancy when interacting with the skin, regardless of how complex, unusual, or unattractive the disorder may appear.
Any hint of reluctance could be so damaging.
It immediately reinforces the patient's self-consciousness and psychological trauma.
We saw this demonstrated clearly in the study mentioned in Chart 55.4, which looked at managing radiation dermatitis.
That study highlighted that while a specific dressing, the interdry ag, provided physical relief from pain, pruritus, and burning, the regular, meaningful nurse-patient interaction was equally therapeutic. The psychosocial element, the feeling of being heard, having control over self-care, and receiving emotional support, significantly increased patient satisfaction and feelings of safety.
So it's a reminder that nursing care has to treat the psychological presentation of the illness just as seriously as the physical.
Exactly.
That was a comprehensive, deeply detailed guide through the assessment of integumentary function. To finalize your understanding, let's condense the central takeaways.
Remember that the skin assessment is far from superficial. It demands structural understanding. The barrier protection of the stratum corneum lipids, the immune surveillance provided by Langerhans cells, and the mechanical vulnerability of the dermal-epidermal junction in older adults.
And master your clinical language. You must move beyond simple descriptive terms and categorize your findings precisely using primary and secondary lesion terminology. Size, distribution, is it linear, zoster-form, and pattern are essential for professional communication and diagnosis.
And elevate the priority of systemic integration. The skin is a visible, accessible diagnostic tool. Recognizing findings like clubbing for chronic hypoxia, spiderangiomas for liver disease, stasis dermatitis for venous insufficiency, or specific opportunistic infections that signal a low CD4 count in HIV. These are often the earliest or most definitive clues to severe internal systemic pathology.
Here is your final provocative thought to carry into your clinical practice, forcing a paradigm shift in how you view this organ. The skin is the only organ where you can directly visualize signs of chronic hypoxia, liver failure, impending amputation due to diabetes, and systemic inflammation, all simply by meticulous inspection and palpation.
So given this immense diagnostic power, how can you ensure a meticulous full-body skin assessment becomes a prioritized, non-negotiable step in your daily routine, even on patients admitted for seemingly unrelated issues.
We encourage you to make that assessment your absolute priority. Thank you for joining us for this deep dive into foundational medical surgical knowledge.
Keep studying, keep asking questions, and we'll catch you next time on The Deep Dive.